Good afternoon, everyone, and welcome to the Baldrige Foundation's Institute for Performance Excellence CEO Roundtable, Systemness, Moving from Disruption and Change to Optimal Performance. As a reminder, due to the high number of participants, everyone will be kept on mute during the presentations. If you have any questions, please submit them to the moderator in the Q&A box located on your control screen. Presenters will answer questions during our panel discussion. Before we get started today, I would like to take a moment and recognize all of our great sponsors and a special thanks to the members of the Mac Baldrige Society who serve as trustees of the Foundation's Institute for Performance Excellence. Here is today's agenda. Today's guests include John Chesser, President and CEO, Gbmc Healthcare System, Ben Sawyer, Vice President, Market Development, About Healthcare and co-host Leader Dialogue, Dr. Chuck Peck, co-host Baldrige Foundation Leader Dialogue Program, and Roger Spoolman, co-host Baldrige Foundation Leader Dialogue Program and moderator. And now I will turn it over to Roger to get us started.
Thank you, Jerry, and thank you all for taking some time today to meet with us. It's our hope, and it's definitely our plan that by the end of this webinar, this hour, that you're saying, man, am I glad I took time to do that. We really want to make this an extremely pragmatic and practical time for you and sharing with you some thoughts that we have and our panelists, some of the experiences that we've had. I think about this when we talk about systemness, moving from disruption and change to optimal performance. It's a topic that doesn't get old, I think. And it's something that continues to be renewed because we have our own forms of disruption that keep changing and morphing. Clearly, COVID was a big part of that disruption. I hesitate to say we're through it, but we're into whatever this phase is. And when we think about disruption and we think about changing our perspective, Simon Sinek, of course, start with why. We were talking about this and in his quote about companies articulating why they do what they do. That healthcare doesn't escape that. We don't get to escape that at all. We can't assume that people are just coming to us because of who we are, but they are asking, why are you doing? In fact, we're asking, why are we doing what we're doing? In light of the fact that there, as we'll talk about today, there are many competitors. Why do we have the privilege of doing this, meeting the needs of our community? And so, we have our guests today, Dr. John Chesser. Thank you, John, for being willing to spend some time with us today. John's got some wonderful insights into how to serve that community and that question of why you do what you do. I love listening to you talk about that. So you're going to really be inspiring for our audience. And just a little bit of a note, if you were hoping to get some insight from David Burke, so were we. And at the last minute, we were not able to get David on. There was just a last minute scheduling change, but he did do a wonderful podcast with Ben and with Chuck. You guys did a great job in pulling out some great insights from David Burke. So we're going to try to also bring that to this conversation today as well. But as we go to the next slide, I want to maybe go through some of these slides rather quickly and ask our panelists, Ben and Chuck and John Chesser, to make some comments on them as we go through them, or not. There's a white paper that we were able to put together. Ben authored a white paper that you will all get a copy of. You'll also get a copy of these slides sent to you over the next couple of days. And we just want to be able to share with you this white paper that actually came from a CEO roundtable that we held in person in Atlanta a couple of months ago with John and some of his colleagues around the country. So we'll talk about that and how you or your CEO might be able to take part in that. We have another one coming up in October, but we'll give you more detail about that a little bit later. But just to set the table, if you'll allow me to just kind of go through these slides fairly quickly, there are obviously some disruptions, workforce disruptions that have occurred that are undeniable. Like I said, when we were dealing with COVID, what in the world was happening to healthcare? What happened while we were dealing with the urgency of COVID? Well, things kept coming at us: workforce disruptions, margin pressures. It makes me wonder, CARES Act money, there are other special support programs that took a little bit of pressure off the margin, but that didn't last very long, did it? And John, I would think you and your team thought about this too. Yeah, that was immediate help, but it certainly wasn't long-term help. So you had to get back to being profitable and focusing on margin. Correct?
Yeah, thanks, Roger. Absolutely. The workforce disruptions have really created problems with margin. In our market, we have a nursing shortage and we're paying premium labor, and at the moment, we are not in the black, we are in the red. It's just another disruptor that we have to deal with.
Yeah. And I heard David Burrick talking about financing, margin pressures and financing, and talking about bond ratings. There's going to be a big asterisk over everybody's financial performance over the last couple of years. And when will we get back to the traditional metrics that Wall Street and the bond rating agencies take a look at? That's all up in the air too, I would imagine. So these are things that we don't have answers to, but we really want to talk about how we're dealing with these and how we stop, maybe not stop, but when do we call victory over the urgent matters and get back to what's really important for our future. The next thing is leadership development. And I've heard of other organizations that put this on hold. They put leadership development on hold. And again, the tyranny of the urgent has really set some things on the back burner. That's critical. And another reason why we believe this webinar and other things that the Baldrige Foundation is providing for leaders is critically important. So now we can go to the next one. Oh, go ahead, Chuck.
Yeah, Roger, I just wanted to make a comment about that last point. I like to relate stories that I read about or hear about because I think they sometimes they tell a lot more than data. But I read a very interesting op-ed done by an intensivist from Brigham and Williams in the New York Times today. And what she was talking about were things that I don't necessarily think we think about as part of these major sort of disruptors. But she was commenting about the fact that, they have patients today that are still concerned that because there are limited visiting hours in a lot of health systems still, that patients and their family members won't be able to be there in their last moments because of the way it was during COVID. She's also very concerned about residency training. And for those of you in the audience who do residency training, there's some very big issues associated with this. For instance, over the last 2 years during COVID, she was pointing out that the interaction with family members in the intensive care unit over large questions like whether to use deep sedation in people who are critically ill, et cetera, that those decisions were over the last 2 years being made by residents and fellows without any interaction with family members who, may have important things to say. And I suppose they could get that information over the phone. But as you know, it's not the same. I know my daughter, who's a palliative care social worker at UCSF, was doing really difficult work with patients and families via Zoom in the intensive care unit, trying to talk to patients via Zoom who were intubated. And I'm sure you've had some of those same, in the audience, those same sort of interactions and serious questions. So the point of the article was, what exactly is the new normal that we're going to go back to? We have a bunch of new interns and residents starting just in a few weeks. Training used to be focused on just the things that we were used to, like congestive heart failure, COPD, asthma, diabetes, et cetera. How do we need to restructure training? How do we need to make up for the lack of training, perhaps, that the residents who had been there for the last 2 years didn't get because of all this? And the fact that a lot of our systems are still closing down surgery. I just had a client who told me the same thing just yesterday, closing down surgery, not because they don't have beds, but they don't have staff to do the surgery. And I'm sure John is also seeing that. So, just some points other than the obvious sometimes that we don't really pay a lot of attention to.
So, Roger, if I could, I wanted to go back and ask that question that we had on slide 1 about why is this debate about why important in the middle of all of this kind of crisis. And for the listeners who don't happen to know, Gbmc was the recipient of the National Quality Baldrige Award in 2020. And John was also the recipient of the Dr. Harry Hertz Leadership Award this year, which was evidence of both strategic and visionary leadership. It's a real honor to have that. So, John, I'm just curious how the leadership system that you put in place with the Baldrige and the clarity around why has impacted these kinds of disruptions and headwinds for you guys in terms of weathering the storm and essentially being super clear about where you're going next. Are you able to hear us, John, or did we miss you?
I think
John
he may be
might
frozen.
He might be frozen. Yeah.
Okay. Well, we'll hold that question
point.
for when he comes
Yeah,
back
no.
on.
Great question. And it really is a good one too, because and your comments too, Chuck. I think about that class of residents and that whole 2 years of postgraduate training. Where are the gaps? Where are the things that they missed out on? Because the volume of surgery went down and there was a lot of palliative care going on because of the increased number of deaths in the ICU because of COVID-related illnesses or comorbidities. It's a whole different curricula, isn't it, of learning, and where are the gaps? And so the point is, we have got to figure out, yes, you've got to deal with the urgent, but also there's the important for the future. And when John gets back, I want to ask him about leadership. Maybe at the end of in the Q&A section, we'll talk about how has this changed his leadership team, because we got some great comments from other CEOs during the roundtable, the in-person roundtable, about again, staff disruption, the turnover that people saw. So there's a lot here. And again, back to our audience, please bear with us. Maybe not all of this is going to be very, very relevant, but hopefully you'll find some things that you can apply right away and you'll be more interested in. This is a slide talking about turnover. Philip Young from Baptist in Northeast Baptist. Where is it?
In San Antonio, Texas.
San Antonio. I thought he was in Texas. That's correct. Yeah.
Mm-hmm.
So he had some great insights, and he said, we experienced a 75% turnover in our leadership team and had staff vacancy of over 25%, which I've heard higher than that. That's not certainly not the highest I've heard, but I was pretty stunned by the 75% turnover of his leadership team. So, and he says the impact being devastating to our culture. Just think of everyone was working on culture, hopefully, the years prior to COVID. Well, did that come to a screeching halt? It really got slowed down, if not absolutely halted. So he says the leadership changes, staff gets worried, the momentum shifts. So all of that work begins to be deconstructed, and we've got to find the time and the energy and enthusiasm to get back to it. The maps here, this will be in the information that you get, but it just talks about where the critical staff shortages are. and what are some of the things that we can do to really appeal or to work on that. The whole notion of travel nurses and agency nursing. I had a guy come to my house to do some work just a few days ago, and lo and behold, his wife, it was an employee of one of my previous systems in town here, and he said, "See that truck? My wife paid for that in 3 months, of travel nursing." His wife was an RN, worked in our system. And she also bought a property. We have a hunting cabin and some property, paid for that. It was quite a thing. But I said, "How's she doing now?" "Oh, she was exhausted." No, so she didn't get back to the job she left. And so it created some relief financially for some people, but created a whole different set of pressure. And so we had people moving around the country, taking advantage of opportunities and helping people out with critical shortages here and there. So,
So Roger, that quote on the bottom from Phil, which was
Yeah.
really interesting as he was stabilizing his organization, he talks about how workforce development and rebuilding our culture then became priority number one for us. And during the retreat, he talks about how he was asking his team, what's it going to take for us to create a world class work environment, and he saw the pandemic as an opportunity to rebuild and to become the best that they can be, and that to avoid the natural instinct of trying to just get back to delivering services and making ends meet in the same way we used to, but instead doing something transformational. And he talked about in the podcast that we just had with him how they focused on some key areas of service delivery, like with total joints, and were able to get contracts with Walmart and other large companies because they showed and demonstrated that excellence, and rearranged a number of different service lines to better meet their community needs. If you recall that from both the CEO Innovation Council as well as that podcast. And it's just interesting to see when you talk about the response to crises like this and moving from disruption and change to innovation, how leaders are reacting to these things. Because we have two choices, right? We could either go, "Woe is me," and what a hassle, and or step forward, which I see a lot of leaders doing to do the kinds of things that Phil's talking about.
Yeah. No, it is a great quote. That was a great discussion too. And we've talked about this before too, Ben, that we seem to be finding leaders are either gravitating towards taking advantage of this situation, this very disruptive change, but what's it, kind of a chrysalis moment, what's going to emerge from the chrysalis in the post-pandemic era. And then there are still some people who are going, how do we get back to 2019? As
Right.
fast as possible.
Right.
And that's not sustainable. We know
Right.
that.
And I don't think that's ever going to happen again. I think
Certainly.
that's over.
Certainly nobody that's on this webinar falls into that camp.
Yeah. So let's just check audio. John, are you able to hear us?
Yes, I'm really sorry, guys.
No worries.
The participants may not know that I'm home because I have COVID, and for some reason our internet just went away. So I'm now connected via my phone.
Well, hey, by the way, we can all relate, so it's not a problem.
Yeah.
Did you happen to hear the question that I asked right before we lost audio contact with you? If not, John, I'll repeat it.
Why don't you just repeat it to make sure?
So the question tied to what Roger was bringing up at the beginning, which is that importance of why, to ground on why, right, during times of crisis. And I had shared with the listening audience of the award that you had won, the National Quality Award from the Baldrige Foundation for 2020, and also the Harry Hertz Leadership Award, and how you had talked about the leadership system that you had put in place and how critical that has been for you all in terms of transitioning through COVID. Can you just discuss that a little bit of why, answering that question of why do we exist in the leadership system, representation of that is so important?
Yes, absolutely. And thanks, Ben. And as you know, sometimes we executives, we lose our way in healthcare, and our people are desperate to see that, especially in not-for-profit healthcare, that we get it, that the why is we're here to serve the community. And our people benefit from reflecting, not spending a lot of time on it, but reflecting on why we're here frequently, because we're all caught up. We're in a tightly coupled, complex system with things coming at us all the time. And it's very easy to get frustrated, and it's very easy to lose sight of the why. So at GBMC, we created our board went off on a visioning retreat 12 years ago and decided to really get serious about our mission, which was in serving the community and health, healing, and hope, and said, on a bad day, we're a little too focused on delivering individual services, and sometimes we were missing what it was that the community really needed from us. And as the population ages and there's more chronic disease, focusing on individual services is not going to make it for a lot of people. So we like to start, we start our leadership system. Our leaders are expected to review the mission, the vision, and our 4 aims at regular intervals to remind people of why we are here.
Yeah. So in terms of these questions that are in front of you, can you still see the screen, John?
Yes.
Okay. So where has that staffing crisis hit?
Even though it's pretty tiny.
Yeah, sorry. Where has the staffing crisis hit GBMC the hardest?
Well, clearly in nursing at the bedside.
Yeah.
And, our nurses have done a phenomenal job, as they have everywhere, to get through COVID. And now to ask them to keep coming back when on certain days we're struggling to have enough people is quite a lot, and it can be very disruptive. And from the leadership perspective, it's an opportunity to really get as innovative as you can. And our core competency at GBMC is redesigning care. So we look for new ways to get the job done. But on certain days, it's a real challenge.
So
Hey, John.
Roger, back to you. I was just interested in that second question. We had that opportunity of having Dr. Gay Landstrom, who's
yeah.
the CNO of Trinity
Health.
Health System, on to talk about some of the innovative approaches that Trinity is using in terms of responding to that nursing crisis. So maybe you can, for the audience, just kind of, talk about a few of those things.
Sure. And now seems a perfect time to put in sort of a shameless plug for Leader Dialogue podcast. And these 2 questions, basically, we're trying to showcase some leaders from some systems who are doing a good job of this and being innovative. And that certainly was one of them. And then the third one is, just leadership topics. How can we help inspire you to lead? We had Clay Scroggins, how to lead when you're not in charge. We've had Michael Bungie Stanier, how to, be more coach-like. We've had some great folks, David Burke, on our podcast. So shameless plug, but back to your question in particular, Ben, Dr. Landstrom talked about things that Trinity was doing. Of course, they're all across the country, so they have a lot of these colors in a lot of these states, and they decided, rather than be just victims of the agencies and having their nursing staff be sort of seduced away by high wages and that sort of thing, they'd start their own internal staffing agency. And that way people could maintain their seniority, they could maintain some of their benefits. And so it didn't solve the whole problem. They still had to do agency staffing, but at least it solved part of the problem. And that we thought that was a very innovative approach. They also did some upskilling of their nurses in a sort of formalized fashion. And it was an opportunity for them to add enrichment to their the staff that they already had, to see if they could then maybe get the skills they needed to staff other higher intensity beds, that sort of thing. So just an example, and we refer you back to Leader Dialogue to check out some of those. Chuck, are you trying to?
So John, if I could distill this down into a very specific question, to get your thought on it. I've looked at all of the most successful clients that I work with, and it seems that there's one thing that they've done that holds true relative to retention and recruitment. And that is that they've really, really focused deeply on the psychological and emotional support areas for their people. So as a specific example, some of them have developed what they call a buddy system, very similar to what the Army does, where you're really attached to somebody at the hip whether you're in a foxhole or wherever you are. And that person and each other sort of each of them give each other the support, the help, the cover they need at times that, like the ones we've been through recently. And I'm just wondering if you've seen that work and how you've addressed that at GBMC.
We'll use the formal buddy system, but we have developed a significant nurse residency program for people joining us, where they get partnered with more senior nurses. We've spent a lot of our leadership system and trying to develop educational programs. We do our lean management system walks every day, and we check in with the people to see how they're doing and make sure they have what they need to get the job done. That there's a lot of opportunity for us to do more and to learn from other organizations to do different things. I think we were in a pretty good place because of our culture until really significant allure of money hit us 7 or 8 months ago. I had one nurse ask me if she could meet with me because she was leaving our organization, and she said to me, you need to know that I love GBMC. And then she said to me, and I want to thank you for coming to the ICU every day during the pandemic to check on us. But I have debts, and I just can't pass up the money. So it's just a reality. And if she had been my daughter, I could have argued against doing what she was doing. But that there are these realities of life right now. You just have to work.
Yeah. And the grass isn't always greener on the other side. The money's greener, but the grass might not be. And so hopefully you get her back and she says, you know what? I didn't have a boss who came up to the ICU every day to check on us. In fact, never knew who that person was. So credit to you. Your leadership
and
is
she
very
did,
attractive.
and she did offer that she would come back as the situation changed, but she needed to take advantage of this opportunity.
That's great. Yeah.
So Roger, back to in the question number 3, this thing about addressing leadership development gaps in this kind of a crisis, when you have an open door and a lure of money and so forth. We had talked before, and I think you had given some suggestions, they're right here, in a previous podcast about some of the practical things that can be takeaways as it relates to leadership.
Yeah, thanks, Ben. Max Dupree is, the first responsibility of a leader is to define reality. The last, say thank you. In between, the leader is a servant. Max Dupree was the founder of Herman Miller. I'm sitting in a Herman Miller chair right now, as a matter of fact, and many of you probably are too. But these practical takeaways, they are it's almost embarrassing. They're so simple. They're not anything very special, but yet they're so important. So talking about encouraging managers to shift their focus from, we have to be reactive. We are so good. Healthcare is so good in a crisis. Everybody pulls together regardless of what your role and status is. Everybody pulls together in a crisis. But at the time comes when we have to stop reacting and start being proactive. And we do the root cause analysis. We say, how do we make sure that never happens again? And so what is that time when we start to shift to proactive? Very important to talk about. Earn back the trust of your colleagues first, and then your patients. We sent so many mixed messages, not because we were, just not paying attention, but we didn't know what was coming next. We didn't know how long this was lasting. And so, being honest and just transparent with our colleagues, and then earning back the trust of our patients. And, John, you talked about people still, cutting back on surgery. We're still restricting visitors. 2 months ago, I won't get into it now, maybe on a podcast, I'll talk about my older brother passed away, just 2 months ago. He was hospitalized, and he was in a situation where they would not let his family come and visit him. And it was definitely part of his demise. I'm certain of it. But, number 3, don't forget your medical staff. Ask them how they're doing. Listen to them. If we think that they're immune from all this stress, we're crazy. No, their surgeons are not able to do as much surgery as they were able to. Now they're stressed because they're catching up. There's been such a backlog. But talk to them, find out how you can help, be responsive to their needs. Number 4, humility looks good on everybody. Just being open, candid, honest, listening, serving people. And one of the things we might talk about a little bit later is humility about our competitors, and people that weren't competitors before, but now we open our eyes, our head's been down dealing with COVID and other urgent matters. We pick our head back up, and we see now we've got a whole bunch of new competitors, mostly in remote presence medicine and some other things like that. Humility. Okay, if we got to catch up, we got to catch up. Or if we were wrong, we got to make it right. And then finally, err on the side of over communication and clarity. We've told patients, stay away. We met them at in our parking lots before they could get into the building. We met them with hazmat suits, and say, don't come in, don't come in. And then now, when do we, how do we communicate? We're sitting around saying, now it's safe to come back in, come on back in, and wondering, where is everybody? I think we have some slides a little bit later that talk about reduction in volumes, in patient activity. Everybody's experiencing it to some extent. And if you look around your town, you see the big banners outside of even fast food restaurants, dining room now open, and it's sort of the same thing for us. Our hospital's now open. You can come back. We want to take care of you. So over communicate, err on the side of over communication.
So this is a table that our good friends from the Health Management Academy provided, and it represents the different members of the C-suite and the priorities that they're looking at, and how the focus seems to be on workforce disruptions, and consumerism is dominating things. John, I'm just curious, as you look at this, whether these are the kinds of things that are bubbling up on your team as well, as you're talking about what's next as you move out of COVID. And if not, kind of what's different in terms of where your priorities and focus are?
No, I think it's a great list, Ben. I think if anything, we are doubling down on our vision and building our patient-centered medical homes, becoming more responsive to what the consumer is asking us for, which is ease of access to a respectful relationship, where we bring expertise to them and we co-own their health outcomes with them once they sign up with us. I think that the disruption of the pandemic, and Gbmc also had a very malignant cyber attack, requires us to get smarter in how we use technology to try to not force office visits when a face-to-face virtual communication will do equally as well.
So go ahead, Chuck, were you going to say something?
Yeah, no. So John, as a physician, I've got to ask this question. So, what are you doing to truly partner, make your physicians feel like they're partners during this time, so that you continue to not only please the patient, but also please the person who tends to be the one in many cases referring the patient? And what are you doing to step that up in terms of listening to your physicians and making sure that the physician strategy is way up on the top of your list as well?
Yeah, so we've worked hard on this to try to have just one chain of command and one org chart, and to have our physicians be us. And maybe it's because I am a physician. So our chief medical officer leads the charge, along with department chairs, office medical directors. They're all part of our strategic planning process. Their voices are heard. It's not a perfect system, but I think we're moving fairly well together. It didn't hurt that in Maryland anyway, the private practice of medicine it has sort of gone through a death. Now all we have is single private equity owned private practicing physicians. Most of our docs are now that are doing the work of our system. Most of them are employed by us, with some exceptions. We do have great relationships with our emergency department physicians, our radiologists, who we don't employ, but we've worked really hard to create a culture of empowerment. We've tried to keep our vision phrase is very simple: to every patient, every time, we will provide the care that we would want for our own loved ones. So when a doc comes to his or her boss, we try to reflect that back. What can we do to help you with whatever your issue is, reflected against that vision statement, that vision phrase.
Thank you.
Hey, Ben,
So, yeah, go ahead, Roger.
I'm just trying to manage the rest of our time, so maybe we could, unless you have something urgent, that I'd like to just dwell just briefly on this slide, talking about, we mentioned earlier some expectations, consumer expectations that we're going to have decreased, maybe even permanent, lower volumes now than we were pre-pandemic levels. And so, we see this in inpatient admission surgeries, ER visits, outpatient surgery and visits. So, and what happens is when we're not looking, or when we're looking at other things, more urgent things, then our competitors creep in and they start providing solutions that we weren't able to give. And so I like Scott Nygaard's quote here. They've been very successful in also a very tough environment as a county facility, quasi-governmental facility. They've got all the restrictions and none of the benefits in their community because they don't get any support from the county. But Scott at Lee Health, talked about the progress that they've made. And basically he said, what got us here isn't going to get us where we need to go in the future. So it creates some really robust conversations around their senior leadership table and asking things like, what's driving the lower volumes? What's changing consumer expectations? How's this going to impact new players coming into it? Both on our side and outside competitors, and how our system's responding to these challenges. So the future will not be like the past. And so it's not, a lot of things are cyclical, but we haven't had a pandemic for over 100 years. So it's really hard to make a cycle observation of that. Let's go to, other considerations. And these came from our roundtable again. And we want to talk a little bit with you, just share some insight with you about annualized thinking and what that is. And these are some solutions. our hope, again, as I said, is to give you some practical applications and some places to go and to research. We'd be happy, any of us, to talk with you more about these things. Feel free to reach out to us. And we do have a question that came through the chat, which I am eager for us to get to. It's a great question. So, but avoiding, a new mindset will produce new results. And how do you do that? This avoiding an annualized thinking trap. One of the things that we did at the, if you could just go to the next slide, Ben, at the roundtable, the Innovation Council with CEOs, is we brought in Brian Moran. And Brian, an author and consultant, and he did a wonderful job of sharing with us this very innovative approach. We highly recommend this book to all of you when you think about planning. And the whole idea is it's a little bit revolutionary, I think. And I love subtitles, get more done in 12 weeks than others do in 12 months. Well, Brian and his partner have built a consulting practice around helping organizations like all of yours to take a look to shorten sort of the cycle time or the planning time, and take every week becomes a month. And so you have the 12-week year. And simply having annualized goals gives you the false sense of security that I've got lots of time. We've got this annual goal, and it's on a calendar year. It's July. We still got plenty of time. No, you start, if you shorten that time frame, compress that time frame, every day is an opportunity for you to make progress or not towards your goal. And it's just a heightened sense of accountability. And so, Chuck, John, Ben, any comments you have about the 12-week year and this whole notion of getting out of this annualized thinking trap?
Yeah, well, I was really struck by the story you gave when you were the interim CEO at Loyola, how you guys tackled the rev cycle challenge that had been pretty persistent using exactly this process. And there were a couple characteristics that jumped out at me. One was you galvanized organizational focus around that issue. So in other words, it didn't just become a part of everything we're trying to solve month over month over month. And by doing so and linking emotionally everyone to it, I remember you talked about how people provided pictures of their family members to say, look, this is why we're doing it, because the people that are being impacted by this rev cycle challenge are just like our family.
Yeah.
And they were able to zero in on finding things that they otherwise wouldn't have uncovered.
Yeah.
You were doing kind of a command and control rapid cycle structure on it, and solved a problem, if I understand right, Raj, that had been persistent for a number of years, and you guys solved it in a matter of weeks.
True. And I suggest that you go back and listen to Dan Isaacson, who's now things worked out well for Dan. He was my VP of finance at Loyola when I was serving there. And now he's Trinity's chief financial officer. But, Dan was outstanding. He did an incredible job of galvanizing the whole team and providing that sense of urgency. But it's, as you said, Ben, it's extraordinary focus, and it's not getting tired, not getting fatigued of that focus. We met every single day, Monday through Friday. And, it was not for long, it was for half an hour, but we had people in the room who could make decisions. Everyone who had the opportunity or had the authority to make decisions. And so, we did not want to have to face the rest of the group if we said on Monday that we'd get something done by Tuesday. And so it was a great experiment, and it really turned out great, and huge turnaround for Loyola, and it's persisted. So
yeah, and just Chuck and John is, John, you as a CEO now, and Chuck having been a health system CEO, have there been times where you've had these recalcitrant problems that have just been persistent, where you kind of almost have to have a focused team or organizational alignment around, let's get this thing done, because it's really compromising our ability to move forward?
Yes, absolutely. I can give you a list of them. It's the concept is shorten the time to action.
Right.
And I love your story as well. We use our lean management system to try to make the changes quickly, but to do it in an organized, systematic fashion so that we can sustain the improved results. And we use monthly report back. We do annual goal setting, but we have monthly targets to improve on each of our goals to assure that we are moving forward.
Yeah, and Ben, as you know, I took over a health system that had 6 days of cash on hand, and we turned that around, and then we're integrated into a much larger health system just 2 years later. And I cannot emphasize the importance of focus and limiting the number of priorities. We limited ourselves to 3 priorities, and that's all we did at every leadership meeting. And that's all we talked about with everyone on the staff that we involved in this. It so happens our 3 were quality and safety. The hospital that I took over again had a leapfrog D score, became an A+. Fiscal stewardship. So we went from 6 days of cash on hand to about 70 over a brief period of time. And employee engagement. We were in the 2nd percentile nationally in employee engagement. We went up to the 65th percentile. And by getting focused attention and holding people accountable to focus on those things and not get caught up in the whirlwind and stop doing things that were not creating value every single day, and letting you know as the leader and as a leadership team what those things were, and getting involvement all the way down to the lowest paid individual in the organization and finding out what they knew they could do to make things better and more efficient. That was the key to the whole thing.
Yeah, that's great insight and great success.
Yeah,
Congrats on that.
congratulations. That was wonderful. Way to go, Chuck. Okay, what I'd like to do again to manage the rest of our time, the next 2 slides are, we spent a fair amount of time. You'll see this in the white paper. We address these things, but these are new tools. These are new tools that maybe we didn't see a need for prior to the pandemic, and or that there wasn't an urgency toward it, but it's real-time situational awareness and operating as one system of care. I've got a question in the Q&A for Ben, and he'll address these 2 slides at least in those questions. But then the next, if we could go to number 14, Ben, is the digital front door. And a lot of people in our discussions, as we've talked to a lot of colleagues around the country, they needed to, because you couldn't bring everybody into the hospital. How do you assess and improve your digital experience with your community? And because of the proliferation of a lot of these opportunities, my community that I serve, and that John, you're talking about, serving your community as your family, and Chuck, your hospital that you were involved in, all of a sudden now it's not geographic boundaries, it's digital boundaries, which basically are no boundaries. And so how do you parse what they have to come to me for and what they can get in a variety of places, in a variety of ways? And how do we then package or repackage our offerings so that our digital front door is much more attractive? Everybody's bought things from Amazon, right? And Ben and I were just talking earlier about what used to be important is price shopping. That's not that important anymore. It's convenience. I can get it tomorrow. I don't even have to leave my house. And so none of, our healthcare systems don't escape that reality. So we have to pay attention to the digital front door.
So,
yeah.
Roger, and I feel like this one ties in as well, right? Which, when you're talking about really diverse demand coming in from all different kinds of portals, the question is, how do you get to yes quickly? And it's part of being able to understand what supply, what capacity do I have, and what's my level of throughput, predictive throughput, to be able to actually create capacity, right? So where does demand and capacity and throughput kind of intersect? Definitely relates to this digital front door, and definitely relates to real-time situational awareness and systemness. And maybe because we're a little bit shy on time, if that's helpful, I can give a little bit of perspective of what we're doing in that regard with the 137 or so health systems that we service in that capacity.
Sure.
So what's interesting in this new market, as you pointed out, is you're competing with organizations that you've never competed with before, right? Whether it's Walmart or CVS or Walgreens or whoever that's coming into your area, and the whole pay provider collision. So the challenge is, how do you know where you have capacity? So if you have a cardiac patient that needs care, do you just bed them because that's convenient and that's the easy path? Or do you have a real-time awareness of what's happening in your service line, your cardiac service line, and know that, hey, they actually just need a cardiac cath and that would be perfect for them, and it's the best environment for the patient. So part of it is being able to understand exactly across the enterprise now, because we're moving away from the acute care model, what capacity do I have across the enterprise? And that is an evolution. Once you know that, which we call care orchestration across your entire system, kind of an enterprise resource visibility, then you have the ability to say yes quickly. Now, there are subpoints to that, right? You have to be able to have service level agreements with your on-call provider so that they say yes when the request is there. There's the need to have computer-assisted dispatch of your winged and wheeled EMS vehicle so you can get them to the right place in the right time. And again, you're dealing with other organizations that are used to high levels of consumer access. So that's part of this whole thing with systemness. And so this notion of being able to have this real-time situational awareness so that you can respond nimbly and be able to then express that in a digital front door, right? So that consumers can access your telemedicine resources or your behavioral health or whatever. And also when you get the patient in, being able to, for example, adjudicate a transition to PAC, post-acute care resources, essentially on admission, so that you're reducing that turnaround time and all the communication and so forth, helps you get to a place where you can actually load balance your supply and demand. And that's a deep topic. Obviously, we talked about it in the CEO Roundtable, and it's in the white paper, so all the listeners will get that. But hopefully that's a bit of a recap on some of these items, Roger, that you've just teed up.
Thanks, Ben. And again, it falls under the category of, what was nice to have before is almost essential now, because we don't have the luxury of a lot of resources, spare resources. We've got to get much more focused, and that's a great example. Well, let's go to the Q&A. We've just got a few more minutes left, and there is a great question. I don't know if you all can see it in the chat from Dr. Stevenson Perez. It's kind of an involved question and some examples. He's talking about appreciates the review, but many national level scientists are becoming concerned that our fundamental approach to science knowledge creation in the US is too anchored to the 20th century approaches. So, three basic examples that he cites here: people who died of COVID. Now in the aftermath of all of this, we've got people finally, I think, in the scientific community saying, you know what, we really didn't know what we thought we knew. And we're still learning things about this and how it behaves and how to treat it, what's realistic, what makes sense. So anyway, it's an very interesting question, talking about New Zealand, Taiwan, Hong Kong, and China, how they've treated things very differently. And boy, I resonate with that, because I think there was a long story, but I had tried to get a registry that was accessible by researchers, and an open source registry by researchers and clinicians. And we're told by the CDC, the NIH, everybody, no, we got it. No, we're fine. And they really weren't. There was a resistance. So yeah, I resonate with this entirely. Supply chain still falling apart. And, we can't blame Ukraine for our supply chain for baby formula, and we can't blame COVID for things, but it's interesting how supply chain is really still around, and we've got to deal with that as health systems. And it just is sort of like, why don't we have this? Oh, supply chain, say no more. No, we need to dig into this and why don't we have this, and what's broken that needs to be fixed. And then finally, AI support systems, not up to meeting the challenges faced in 2022, cybersecurity attacks. John, you just mentioned your malicious attack, your system, and others are experiencing it. But anyway, the question that he leaves us with is, any ideas for making our platforms for creating U.S. science knowledge more reliable? Anybody have a thought about that?
Well, part of it is bringing the information that is the latest available to those that are using that information to make decisions, right? So part of that is a technology process, and leveraging all of those kinds of technology assets, whether it's artificial intelligence or other types of electronic communication, which assumes then that the rigorous analysis of data and conclusions that is then going to be delivered to those providers and people that are making those decisions is also improved in terms of its application.
Yeah.
Well, I don't think you have to have a socialized medicine structure of practice in the United States in order to make some tough decisions around interoperability. Mm-hmm. And if you don't trust the government to hold all the data that's out there, that's just in different systems, then having some independent organization formed that's proactive and constantly scanning the horizon. I think that's the other issue that the doctor's implying. I don't know for a fact, so I apologize if I'm wrong, but I think for years in medicine, at the hospital level, at the physician level, at the government level, prior to this pandemic, we were all just sort of admiring the problem. Yep. And I think we continue to admire the problem. And I think we have to be much more proactive. I mean, we have systems that are 24/7 monitoring whether any hostile missiles are flying at us from other countries. I don't think we've taken. I think we sort of thought we had it covered in the U.S. Healthcare system, and I think it's become very, very exposed and very obvious through this. What happened during the pandemic, even at the highest levels of government, that we didn't have any of this covered. And we kind of fell our way through it. And we couldn't even get agreement amongst the highest level healthcare agencies on how to do it, what to do it, why to do it, where to do it. And I think it calls for some sort of centralized mechanism to be on the lookout and to be and really be a think tank and innovative in terms of what we're going to do next. Because what drives me nuts is listening to people and healthcare leaders talk about that. I just wish it would go back to 2019. And my response to them, having been a patient and in the system for many, many years, is, it wasn't that great in 2019. I think we can do better than that.
Yeah. Hey, Roger, I know we're right up against the hour, so we're having a couple questions come in that I think is going to be germane probably to all listeners. One is, how can I get more information? So one of the questions is, how can I learn more about systemness and operating as one system of care? Another one is, where can I get a copy of the white paper and so forth? So let me just reiterate a couple of the things there. So Aaron Sellers, who is the Senior Event Coordinator for the Baldrige Foundation, is planning on sending out to all of the registrants the white paper that came out of our CEO Innovation Council. So a lot of what was discussed here is elucidated within that white paper. And then we, about a week later from now, the podcast or the virtual roundtable will be made available via video, as well as there will be this deck that is then also sent out by Aaron to the registrants. So that information will be forthcoming in kind of two waves. And to your point, Roger, if any of the registrants have any questions or want to follow up on specific things, we're going to be doing podcasts around that, correct? In other words, having guests on, because we're trying to make this super relevant. And
Plus,
also,
I've
if
got
any,
a bunch of questions that I didn't get answered. So we're gonna
exactly. And also individually, if people have questions and we're able to provide some answers to them, and John, I'm assuming you would be the same, to be able to answer questions of other executives that are trying to get to the level of performance that GBMC has done, that we would be happy to try to support that and answer those questions. Is that true, panelists?
Yes.
Absolutely.
Yeah.
All
Thanks,
right, very
Ben.
good.
Thanks for that reminder. And everyone, thank you so much for spending an hour with us. Watch your email for these things that Ben has promised, and reach out to us. We're happy to serve you in any way we can. I think the bottom line, final comment, Chuck, just listening to your frustration, it just points out to me that what never goes out of style and what never is not is okay, we've had enough leadership. We've had enough inspirational leadership. No more. That's never been said, never will be said. So we encourage all of you to continue to improve your own personal leadership. Be better leaders, because your people deserve it. Thanks so much, and we'll see you next time.